Diana Bowen. It's nice to meet you all. I'm a assistant professor at Northwestern, and I work actually both at the Children's Hospital and the Adult Hospital here in Chicago. So it's I do have a congenitalism practice where I see patients both in peds and adults. So it's been nice to develop that and see the kind of continuity of care of things exactly like this. So hopefully we can have a nice discussion about utricles today. And so I didn't know if you want me to present your case as just kind of a jumping off point, just to say,
that would be great. Yeah, thanks.
Yeah, this is what we found, and then we'll talk about utricles, and then maybe at the end we can just talk about what to do.
Yes.
So this is an 11-ish-year-old male who has a known history of a midshaft hypospadias, also had a right inguinal hernia, and underwent a 2-stage hypospadias repair, from what I understand, with a pretty long preputial graft that was then tubularized. There was some question with the initial SP tube of a potential fistula and migration, I guess.
Yeah, there was an episode where it ended up in his rectum, definitely. Yeah.
And was that was through the posterior bladder wall, or that was through the posterior urethra?
Well, we have no idea. And I'm wondering now if it was through the prostatic utricle.
Right. Yeah, that's what it kind of.
At that time, I didn't know he had a prostatic utricle.
Yeah. Yeah. So nevertheless, recovered from that, had a 2nd stage hypospadias repair, and then did have one fistula that was repaired, but it sounds like since then has really struggled mostly with BXO, lichen sclerosis, which has caused some narrowing of the distal urethra, leading him first to have recurrent epididymoarchitis, then difficulty voiding, and then upon inspection kind of noticed these 2 things, both the lichen sclerosis and scarred urethra, and then this large utricle. So the questions in this case are, I think, kind of how to manage both at the same time, in what order, but specifically the prostatic utricle. Why did it show up, and what do we do about it in this 11-year-old? So that is the setup for our lecture. And so we're just going to review, what is a prostatic utricle, and only a couple lines on embryology because it's confusing for everyone. Talk about the common clinical scenarios where we usually see these, which is most often with our hypospadiac kids. Talk about some of the diagnostic studies that we can use to further define prostatic utricles. What are the indications for actually doing something about a utricle? What are the different surgical approaches to a utricle? And then just some long-term considerations. I'm kind of always interested in what's the long-term effect, and what's going to happen when these kids are adults and I see them in my clinic, and how do we manage their condition. So, and feel free to stop me at any time. I know Zoom lectures are awkward, but happy to stop and take questions. So we think about a prostatic utricle. What it is just a vestigial structure of the Mullerian duct. And so if you look in kind of any man's prostate, you'll see an actual utricle. It's usually just a little divot, but it can become this enlarged cavity arising from the posterior urethra. It should be located generally between the 2 ejaculatory ducts. And so you can kind of see them here on this cartoon characterization within the vira montanum. Just some other anatomy, just because I know we're, not all of us think about it all the time. When you think about the posterior side of the bladder and the prostate, you have your vas deferens coming in here. And you have the ejaculatory duct, which is the confluence of the seminal vesicle and the ductus deferens coming in here. And so then on the inner side of the prostate and the bulbourethra, you can see these 2 ejaculatory ducts coming in and emptying the semen. So I think that's just good to keep in mind when we start talking about surgical approaches and, considerations. So prostatic utricles may not be demonstrated on voiding cystourethropography, but usually you can see them on cystoscopy, as was the case with Dr. Ramprasad's case, or retrograde urethropography. Most of the time they're asymptomatic, but we'll talk about why they become symptomatic and what kind of symptoms. And often you see them within this triad of proximal hypospadias, cryptorchidism possibly, and this utricle. So the embryology, again, it's from the Mullerian duct. The Mullerian ducts develop in females into the fallopian tubes, the uterus, the proximal 2/3 of the vagina. The distal third is from the urogenital sinus. But then these structures regress when you get Mullerian inhibitory substance in a male. The prostatic utricle corresponds to the very caudal end of the Mullerian duct. And that should regress in boys by the effect of MIS. But as kind of makes sense, you know, if you have fluctuations in endocrine pathways, MIS, all of these things that we see in severe hypospadias in the kind of DSD spectrum, and by DSD I mean differences of sex development, formerly known as intersex, it kind of makes sense why the prostatic utricle might then not regress and be more like a vaginal structure if you have these endocrine disruptions that we see in very severe proximal hypospadias. That's enough for the embryology. So clinical presentation, like I mentioned, most of the time these are asymptomatic. They're incidental findings, and they're often found when we're working someone up who has a proximal hypospadias or who has a difference of sex development. And as part of those studies, we find this utricle. Sometimes they do have symptoms though, and they might present later in life, such as the case with a hypospadias where suddenly you're fixing the hypospadias, you give them outflow resistance at their distal urethra, and now all of a sudden they're getting symptoms from this enlarging prostatic utricle. So symptoms can be just as simple as just lower urinary tract symptoms, dysuria, urgency, post-void dribbling. So that, or the kind of secondary incontinence that I mentioned, you can trap urine and then the patient can void to completion, but then they have urine left and that comes out. Urethral discharge occasionally, but most often I would say you see recurrent UTIs or epididymoechitis. Later in life, you might see patients, and we're going to talk about the difference between a true prostatic utricle and just a Mullerian duct cyst, but you can see patients later in life coming in with things like hematospermia, infertility, stones, and those could, you know, tip you off or lead you down to find a prostatic utricle or Mullerian remnant.
Well, so, one thing I noticed, sorry,
yeah, go ahead.
One thing I noticed is quite a few of the proximal hypospadias. I've had a couple of boys where we had difficulty catheterize them uretrally, and that was the clue, because it kept going into the utricle rather than going into the bladder, and that was the clue that eventually, subsequently, you found the utricle. So it's kind of something,
yeah, for sure. And that's like a classic boards question that you get, which is, you know, you have trouble with a little baby, which otherwise you shouldn't have trouble catheterizing. It's usually because you're going into the utricle. And so again, in the spirit of boards, you don't need to necessarily do anything besides try to angle the catheter to get it into the bladder, unless they become symptomatic later. But yeah, definitely. So, you know, if you kind of look at the literature, there's case series, which is what I made this lecture off of, that are, you know, 40 to 50 patients here and there every couple of decades. But this was an early paper that looked at 44 hypospadic patients without DSD, and they found abnormalities. They found an abnormal prostatic utricle, and they showed that as you got more severe, you were more likely to find it. So a perineal meatus, 57%, penoscrotal 10%, and none with a penile hypospadia. So you can look, you know, in the literature, but I would say what's generally accepted is that 11 to 14% of proximal hypospadias will have a utricle, but up to 50% in perineal hypospadias. So it's definitely something to keep in mind when you're working these patients up, and then when you take them to surgery. Oh, look, my good friend Trudy is on the line. Hi, Trudy.
Yeah, she said she knew you from top.
I'm not good at Zoom, so I can't see the chat box if anyone's saying, but okay, we'll keep moving. So just like you were saying, enlarged utricle can sometimes hinder catheter placement. And so it catches the tip of the catheter in the opening. And so, you know, what we usually do is when we're putting in our small 8 or 10 French catheters for hypospadias is we'll put like a lacrimal duct probe in and angle it. And that helps just kind of angle it. It's like creating a Coude catheter out of a small little catheter, and that can help you get into the bladder. So they necessitate caution during evaluation. And again, you have to be careful because once you create that outflow resistance with your hypospadias repair, you may render a utricle that was asymptomatic symptomatic. That's not to say you should take it out preventatively, but it's something that you need to know so that when the patient starts coming back with symptoms, it's kind of top of your mind. And then always you want to think about a disorder difference of sex development when you're thinking about these patients. If they, certainly if they, you know, the rule is kind of 2 of 3. So if they have a hypospadias and a unilateral non-palpable testis, they should be worked up. If you have a suspicion with a really proximal hypospadias and any other kind of abnormalities, probably getting a karyotype is a good idea. And it just may help categorize their hypospadias within a syndrome, especially if there are other non-genital abnormalities that you find. There's been debate about the role of karyotyping in truly isolated hypospadias, even the proximal cases. And I would say there's certainly no standard right now for doing that, but I think it's very reasonable to consider. So what I thought was interesting was this paper on prostatic utricles within boys with normal external genitalia. And so this was a group that did a comparative study. So they took 64 patients with hypospadias who were basically found incidentally to have prostatic utricles because of the studies they underwent. So they put them as a separate group because it wasn't fair to compare them with symptomatic patients. So then they compared 70 males with hypospadias and symptoms compared to 23 males with external genitalia that was normal, who also presented with LUTS and were found to have a prostatic utricle. I thought it was interesting. I mean, basically their conclusion, you know, all patients in the normal group then underwent surgery because the symptoms could be attributed alone to the utricle, whereas with the hypospadias, it could be from, you know, various other abnormalities or outflow obstruction, things like that. These were all the different symptoms that the patients had. But, you know, I would say it's interesting because you have to kind of be careful anytime someone's using surgery as the end or the outcome because they chose surgery. So I thought it was an interesting study. 50% of the hypospadias group required surgical excision, 100% of the normal external genitalia group required it. And so they advocate for endoscopic and radiologic evaluation of all boys with proximal hypospadias, and then also boys with normal external genitalia who have LUTS that's not explained by like an ultrasound up front. They say they should undergo cystoscopy. I think that's a little aggressive because they don't have a denominator to this study, right? Like how many boys show up with lower urinary tract symptoms and it's not because of a prostatic utricle. So I think just, again, thinking in the back of your mind, if something doesn't seem right, that you should consider it, but it's probably not your first line. Okay, so speaking of diagnostic studies, so VCUG or MCUG, voiding cystourethropography, in most cases will show this. You know, this is, again, most of you I'm sure know this, a catheter is placed, you fill the bladder with contrast, and then you have the child void and it delineates the urethra. And then here you can see posteriorly, it delineates this extra structure coming off. Occasionally, if it's a stenotic meatus to the stenotic orifice, or for other reasons, you may not see it. But I would say almost always, if you did a retrograde urethrogram or you did cystoscopy, you definitely see it. Ultrasound and MRI can also be helpful tools. I would say we tend to do the MRIs in the older patients that we find. It helps delineate things. But ultrasound is pretty good too. And there's actually an interesting study that compared ultrasound, and actually retrograde urethrogram. So they took 80 patients, a pretty wide range, babies all the way to 16 years of age, and they found prostatic utricles in 36 patients, and that was confirmed by cysto. 44 did not, 36 had them. And so out of those 36 patients, ultrasound found the utricle in 75%, and retrograde urethrogram found it in 83%. So retrograde urethrogram is slightly more sensitive than ultrasound, but given that ultrasound is so much less invasive and easier to use, they recommend that's probably still the first line. So you're looking at, from this study, 75% detection rate, basically. So if you don't detect it, you have to have a strong clinical suspicion to then look with a cystoscopy. Cystoscopy, this is just a couple examples of how this might look. It's diagnostic, but it's also potentially therapeutic. And we'll talk about, some of the surgical options that you can do endoscopically. But I think it's important when you're in there looking, you want to look, of course, for the location and make sure it truly is a prostatic utricle. It's in the region of the verumontanum. You want to look for the ejaculatory ducts and see if you can identify them, which may not be possible. It can be very hard to see, but it'd be helpful to know if there's an ectopic insertion before you plan your surgery. Okay, so any questions before I go into indications for intervention?
I find that I've done a few MCUGs and it hasn't showed up, and I don't know why, because it was, a wide opening when you did the cystoscopy, and it still didn't show up in the MCUG. I have to say I haven't done retrogrades, and maybe that might be more sensitive, and maybe we could consider that. But have you used ultrasound much? I mean, I haven't tried to even ask our department to do ultrasound to look for it.
No, I mean, I think ultrasound is still kind of a good screening tool. I think you're only going to see it if it's really large. So that's the drawback. So I think, in any of the DSD patients or the proximal hypo patients, if you have a strong suspicion, I think a retrograde study might be a good idea.
So maybe we'll consider that in future.
But it's hard to know because often you're doing the VCUG because you're looking for other reasons for infections and things like that. But I think it has something to do with just that antegrade flow bypassing the mouth of the tick.
So, I think there's a lot of flow dynamics that go on that we don't understand.
Right, and you probably caught it in the hypospadias kid because his distal urethra is pretty tight, and so the path of least resistance is into the utricle now. So, okay. So when we talk about surgery, right, and indications, whenever you read the literature, this is just my soapbox moment. Rare conditions and surgical papers are methodologically flawed by nature because they're all using surgery as the outcome, and the surgeon decides on that outcome. So this is why research in these particular areas are hard. But I think important that people are sharing these case series and sharing how to do these different surgical modalities, how to perform them. So again, most cases are asymptomatic. This study, which was from the 70s and is quoted in a lot of papers still, estimated that about 30% may manifest some clinical symptoms in childhood and go on to potentially need treatment. So that's kind of your general ballpark for who's going to need treatment, it's 30%. So indications would be recurrent UTIs, and we think that's because of the stasis within the utricle or stones. Recurrent epididymoarchitis, of course. Inability to catheterize just if the child is going to need CIC, and that's going to become, prohibitive to them doing it. And then, of course, there are other kind of rare symptoms if they're really bothersome to the child or to the family. But those are the main ones that we see needing to take out the utricle. So again, shouldn't be based on just the size of the cavity, just because it's a really large utricle. Shouldn't be that it just exists. And then we'll talk at the end about this kind of undefined risk of malignancy, but I would say right now that's not a reason to take it out. So surgical approaches. So it's a difficult area to access. There are a lot of important structures around it. And it's a rare condition. And all that means that there's no consensus on the best way to do that. And you ask everybody, around, and they'll all give you different answers. But I think that there are lots of good options too, is the other way to look at it. So all of these options have been described, and we'll go through some of them, not all of them. So endoscopic. There's a couple different methods that people have described. So Doug Huesman at Mayo, I think is a very smart man, so I listened to him. Basically published this case series of 12 patients. These were utricles that had had infections and needed to be taken out. And he essentially fulgurated the utricle, used a bug bee, did circumferential fulguration, and then placed a council tip catheter and an SP tube. And then he did do a VCG to verify obliteration of the cavity. And he found that it was about 87% successful. But the caveat is that some of those counted in the 87% did require multiple treatments to get to that 87%. But they highlight the low morbidity and the high rate of success as this being a good option. I would say the cons of this would be, if it fails, will it make the excision more difficult? Potentially. It can take multiple trips to the operating room. Again, you're not taking out the cavity, and there's this remote possibility of malignancy. And I think in all of these approaches, this is something to consider, but the close proximity of the ejaculatory ducts. And so you're not just cutting here, you're fulgurating. And so you have to really know that you're not going to fulgurate across an ectopic ejaculatory duct or vas. So that's one option. Another endoscopic option is just marsupialization. So instead of boveeing the mucosa and collapsing it with fulguration, you can marsupialize and essentially open the cavity to the urethra and just make it a wide mouth so that it drains better. I've seen this with both the laser and also the loop resectoscope. I think the pros of this would be, again, low risk of injury as long as you can identify the vas. It's useful in the really stenotic ones. And sometimes people have done it under transrectal ultrasound guidance so that they can basically cut right down into the tick and make a wide mouth. But essentially, you just incise that dorsal wall between the urethra and the utricle and just make it very wide so that it can drain.
So the question with this is, what if you don't see the ejaculatory ducts? How do you know you're not going to? Because most times it's difficult to see them in kids, I think.
Yeah, I mean, I think it's hard. I think theoretically, if you stay midline, you should be staying away from them. And so that's what makes me prefer this over the, just bug being everywhere, because I would worry about the spread of electrocautery. But it is something to consider. I think that, here in the marsupialization, they kind of go above where probably the ejaculatory ducts come in with the prostatic utricle. And with the use of transrectal ultrasound, they basically just go right down into the tick. So that would likely be safer. So we actually at this institution did one patient. It was a patient with dentist rash who had a proximal hypospadias and undescended testes and a large mullerian remnant. Did an anterior sagittal transrectal approach. And so this is called the Astra. And essentially you just, you place the child in kind of a prone jackknife position, and you incise again right in the midline through their anterior wall of the rectum. And that allows you to come right down onto the prostatic utricle. At our institution, we do it with pediatric surgery just to have more hands on deck, and they're obviously more comfortable than closing the sphincter and the rectal wall. But it provides really good exposure and can be useful in some cases. But it is morbid, and Obviously, the patient has to be in the hospital for a while and need a full bowel prep, and there are risks to that. But we've used the Astra approach in a couple of UG sinus cases and one Mullerian remnant, and it worked well.
Do you put anything in the utricle itself, like a guide wire or something that might help you? Or
Yeah, great question. So before we do the Astra, the baby we do a cystoscopy, and we basically place a Fogarty balloon or council tip catheter into the Mullerian remnant, and then you leave that in place, flip the baby over still sterilely, and keep that in so you can palpate and identify it.
okay.
Yeah. So open transvesical excision. So caveat, I've never done this, but this is essentially going through, as it sounds, going through the bladder. So you make a fan and steel incision, identify your ureters, and then you go basically through a longitudinal incision right through the trigone of the bladder. You expose the prostatic utricle. Same deal where you would place a catheter into it. Previously, you mobilize on each side. And then, this is in all of these open, and we'll talk about lap and robotic cases, still really important to identify the vas and the ejaculatory ducts. Here, I think that, again, this applies to everything. When you encounter the vas and it's entering ectopically and it's entering into the utricle, that's something you have to be prepared for, and something you have to talk to the parents about beforehand. But as best you can in all of these cases, I think, in my opinion, trying to identify it and preserve a little part of the utricle, even if it means having a small remnant, if the vas is going into it, I think is preferable. But lots of other surgeons and cases have kind of reported if it's ectopic to the utricle, they will excise the vas after a discussion with, or excuse me, incise the vas after a discussion with the family. You close the urethral stump, and we're going to talk a little bit more about that later. Close the urethral stump and leave a catheter in place. Pros, great visualization. Cons, I feel like this is fairly morbid, and I think there's a risk of neurovascular injury, so this would not be my preferred approach.
Sounds scary.
Yeah, right? I think it sounds really scary. So anyways, so laparoscopic excision. The Bristol group actually put out a nice video of this. I was going to play some parts of it. I won't play the whole thing. But this was the MCUG. And it's interesting because essentially it's a little similar to our case, right? The hypospadias was repaired in 2 stages, and then after that, the child developed these recurrent UTIs and epididymoarchitis. They found that the repair looked okay, but then that the child had this utricle. So you can see fairly large there. And here it is on retrograde study, and here it is on ultrasound. So I'll turn the volume back on here.
Advanced into the utricle in a way that facilitated the transillumination of the utricle in the laparoscopic view. The bladder was then hitched to the anterior abdominal wall, and the rectovesical pouch was opened.
And I think just like you would do like a bladder diverticulum, where I would put a scope into the tick, and then robotically come in so I can identify it by the light. I think the same thing applies here. If you can leave a scope in there, a balloon too, but I think a scope really helps if you're going in laparoscopically so you can see the light.
Vas preservation would have been at the expense of leaving a residual of the utricle behind. They elected for a vasectomy to facilitate resection of as much as possible of the utricle to avoid recurrence of the infections that they had suffered before. The scope was then used to move the utricle horizontally and vertically to create counter-traction movement for better viewing and dissection. Vasectomy was then completed bilaterally, as they were obviously inserted into the utricle.
I wonder if someone is looking through the scope while they're doing this to see where they ligating. Yeah.
Yeah, I don't think it's a bad idea. That's usually what I
Yeah.
have an assistant at the bedside. You know, and you can kind of take a look at the camera as you're doing it to make sure you're getting around it.
Excision of the utricle was completed by the means of a bipolar device.
So
It's been doing very well.
And obviously he's perfect. So, you know, I think that was a good video of just kind of how you can help identify it laparoscopically. I think it's a nice option. I think the exposure of the vas, again, I think if it's inserting ectopically really high on the utricle, you may have no choice. But I think in my mind, I probably try to preserve it if all possible, unless, you know, the parents just say there's absolutely no way I want more infections of the testicle, which can also, of course, impair fertility later. And so it's a delicate choice. But this was a paper that I found that compared laparoscopic versus open. I think, you know, it kind of just shows all the typical things that we see in laparoscopic papers, where there's a shorter operative time, lower EBL, and a shorter hospital stay. And so I think, you know, it's a feasible approach. I think, you know, we tend to do things robotically because we have a robot, maybe it's a little easier to sew, but I think lap versus robot, there's probably not a huge difference here. I think the same things apply. You need to be careful of all of the different structures around. And then
we don't have a robot, so we don't have that problem.
I don't think you need to, like, we're just like, oh, we have a robot, we'll do it robotically. The Brazil group published on this one. I won't bore you with it, but there's a couple good
dysplastic undescended testis left utricular cyst with very low confluence to the urethra. We propose a moving immediately to the prostatic.
So I like this because they show you the
same finding
the vas
was
deferens
confirmed on the left side. We open the peritoneum and dissect the right vas deferens majorly until the dome of the cyst could have been identified.
I like the music too.
Yeah, very soothing.
In the bladder, and the cyst was created.
So I think they do a nice job of exposing the vasa first and then coming down. They end up taking them anyways, but oh.
I know it hurts. All the boys are going.
Yeah.
In order to dissect the posterior surface of the utricle cyst,
Okay.
And started to dissect.
I think we get the idea. Okay, so counseling, you know, I like everything. I think the comfort and experience of the surgeon is important. But I do think, you know, in this day and age, we all do laparoscopy, and I think the laparoscopic approach is very reasonable for a lot of these. If you think there's a reason that the endoscopic approach won't work, if it's just too large a cavity, if it's open but he's still getting infections, things like that, and you feel like you need to excise it. And then I think talking about the goals with the family. So again, I know we've talked about this, but I think you just need to think about the possibility of the insertion of the vas into the utricle. It certainly is there in a lot of case reports, and try to preserve the vas at the expense of a complete excision, only if you really can't fully separate it off, and definitely talk about this with the family ahead of time. So we'll close out with just a few long-term considerations. You know, in adults, not previously identified, usually what these adults come in with is actually, you know, utricle cysts, not true prostatic utricle cavities. But and so that's different than, right, the large communication with the urethra versus the cyst, which is just a round midline cyst, and it doesn't usually communicate with the prostatic urethra. Kind of an unknown prevalence. There was one random study I found that showed 1% prevalence on autopsy specimens. But this was a series of, I think, 66 patients, but who were found to have adult cysts. And what they came in with were kind of similar findings, UTIs, adult findings of hematospermia, ejaculatory disturbances, but recurrent testicular pain, LUTs, and some were incidental as well. And they ranged pretty far in age when they showed up. But interestingly, the size of the cyst didn't influence the indication for invasive treatment. And about 42% underwent surgery. A lot of them were just punctures or endoscopic opening or marsupialization. They're cysts, they're smaller. Not a lot of them are getting taken out through open excision. But I thought that was just kind of interesting to think about in the context of how you might see patients, especially for the adults. Malignancy is something that I kind of was always wondered about. So we know that prostatic utricles are usually benign, but there are reports of malignancies out there. This 3% report, really came from a while ago. And I think I think we don't really know the true denominator. So we don't really know the true incidence of malignancy, but still good to know that it's out there. And the fact that it can present as clear cell, squamous, transitional cell, endometrial cancer, I think is really interesting and kind of speaks back to also the embryology and the fact that it comes from the a Mullerian remnant, but also the UG sinus. And so you get all these different histopathology types that are possible. Age can be anywhere from 16, clear cell, 39 in endometrial, and I think some older ones have been reported too. This was a case report that I found that was just kind of jarring. It was a transitional cell carcinoma in a 21-year-old, and he presented with hematuria and lower abdominal pain, and he actually had a history of a penoscrotal hypospadias and an undescended testicle, and he underwent a prostatectomy. And pretty much all of the reports that I've seen, present with hematuria, hematospermia, something. And so that's, hopefully the good news that there will hopefully be symptoms. And so, we don't need to worry as much about, again, prophylactically taking these out. But I think, more to come. And it would be great if we could combine centers for these rare diseases and really come up with a true large case series to see is there actually a heightened risk, and should we be, taking these out, similar to how we don't know the real answer for like urachal remnants, right? Lastly, fertility. So, males can present later with these Mullerian duct cysts for infertility. And so, like we talked about in that case series, endoscopic management is usually best for this. In terms of the kids with prostatic utricles that then grow up in 20 years and want to have kids, there's really no literature on that. I worry about that. I think that you have to worry about if they had surgery, but I think you probably also have to worry about if they didn't have surgery, and whether they can deliver sperm, especially if they've had recurrent episodes of epididymoarchitis. That's something that they definitely need to probably see a specialist for when it comes time. So my conclusions are not really conclusions, they're more like questions. Should we be screening all patients with proximal hypospadias or let the symptoms guide you? Which approach is best? And I think my only conclusion is that shared decision making with the parents and the child regarding management is important. And in my opinion, making attempts to spare the vas is important. So, I don't know if anyone wants to now chime in with what we should do with this prostatic utricle, but probably be a good discussion.
Yeah, I would love to hear what everybody thinks. Because I have no clue. The good news is, I have to say, touch wood, maybe COVID was a good thing for him. since COVID, he's been very well. He hasn't had one single episode of epididymitis. So his father is in fact saying that the school is starting back. He wants him to stay at home because he's been so well at home.
And
yeah, do you think puberty has, because he's now going into puberty, do you think puberty has any effect on it?
On the utricle?
I mean, the symptoms in terms of, you know, the prostatic enlargement, and I don't know.
I don't think we know that. I would think, has he had his buccal graft? Have you?
No, he hasn't. He hasn't had anything done for the distal scarring yet, because the dad tells me that things are better. So we're waiting to see. Yeah.
Yeah, I mean, for him, I just think you have to rule out the distal obstruction and the scarring and outflow obstruction. And I just wonder if once you do that, if he won't have symptoms anymore.
Yeah. But did you see the cystogram wasn't great, but they definitely looked like there was reflux along the right vas.
Yeah, I did see
the
that.
cystogram, and his symptoms are mostly on the right side. And his father, actually, who is some high-ranking police officer, to make matters worse, is very intimidating, 6 foot tall. Anyway, so he says to me, he said, well, why don't you just do a vasectomy on that side? Because he's been reading it up. And he said, well, in any case, that testicle looks terrible, and, you know, because it's really hard, and it's like, so, I mean, I don't know. I haven't thought about it, because obviously that'll be less invasive. Just do a vasectomy on the right side, you know.
Yeah, I don't know. But if you can solve the problem, I mean, you can't bring the testicle back, but you could save whatever is there and save the vas by opening up that urethra. Do you think that would make a difference?
Yeah, I mean, I think his distal urethra is a problem, and it's going to be a problem in long term. So I think he does need a buccal graft at some point, you know, just, but they're not really keen to do anything right now because he's not so symptomatic anymore.
Sure.
So I'm just kind of waiting. But I think my feeling is, certainly from the reading and what you've said, I'm glad we kind of agree on it, is one, is really based on his symptoms. And two, the family have to understand the risk of infertility is very high.
Yeah.
Even because of the infections or because of the anatomy there.
Yeah.
So whatever we do, he probably will be infertile, you know, so they have to just decide if they really want to go and have the surgery based on that. But my feeling with them is, because he's not having symptoms now, they probably wouldn't want to push for surgery. But definitely in the long term, I think I'll keep an eye on the distal urethra and probably decide to do a buccal mucosa if things get worse.
Yeah, I mean, especially because the symptoms really coincided with after his second stage, you know.
Yeah.
And he was pretty old, so the fact that he never had symptoms before makes me think that if you open that up and give him a robust urethra, that maybe you won't have to do anything.
My concern with this whole episode that happened with the catheter coming out his rectum, it really kind of bothers me, because if we are going to do laparoscopic or anything, or even open, there probably is going to be some scarring between the rectum and the utricle itself. And in fact, when I scope him and I put my finger in his rectum, I mean, it is so close to his rectum. It's like, it's basically on the rectal wall.
Yeah.
You know?
Yeah, for sure. I mean, you could always stick a laparoscope in, and if it just looks too tough, you know, do it open. But I almost wonder if doing something like an Astra would help, because you're there anyways. But do you really think there was a fistula? Because I mean,
why was you? Because I mean, we saw Dr. Kublal. Please report. Dr. Kublal is the one. There was a catheter in his rectum.
Yeah. Okay.
Yes, it's true. It's true. I saw it myself. It was there.
Okay. Fair enough.
She was equally horrified.
Yeah. And when you scoped the utricle, was it wide mouthed or was it stenotic?
It was very wide mouthed. So that was why I was a bit, you know, perplexed as to why it was causing so much.
I mean, I think then probably, you know, endoscopic isn't really going to help you unless you ablate it.
Yeah.
But I just think more and more then it's an outflow obstruction problem. You know,
So
but if-
deal with that first and then
think so.
decide if we need to, yeah. Yeah, great. That was a really good lecture. Katie, we recorded it, right? Did we?
Yeah, it's being recorded.
Okay, and you're gonna put it on where? On
I'll put it on YouTube, but I can also email you the link.
right. So if you email me the link, then anyone who wasn't here, because I think it was a really nice job from Dr. Bowen, for a very, difficult condition to treat. Yeah.
Yeah, it's a tough one, but interesting every time.
Yeah. Well, I'm glad that you equally perplexed by it as I am. I was thinking,
It's tough. Like anyone who says that these cases are easy, is lying to you. So
yeah. And I mean, I have quite a few boys, and none of them have problems other than him. There's
Mhm.
quite a few of the proximal hypospadias who have huge
Right.
utricles. It never bothers them. They've never had epididymocarditis. He's the only one, which is
Yeah.
kind of
Right.
annoying. Yeah.
Yes, very
So-
much.
And I mean, I don't know about this risk of malignancy. I haven't really kind of said that to anyone.
I think it's really hard. It's just all case reports, and again, we don't have a denominator, so I'm
And is it
not sure.
coincidental? Is it caused by the utricle? Who knows?
Right. I just think I don't think necessarily that should be part of counseling in these kids yet until we know a little bit more. But good to know that it's out there.
Yeah, anyone has any comments or questions for Dr. Bowen, or any suggestion actually for Katie about what other lectures you all would like to hear about? The residents? Anyone?
Hello?
Hi, Trudy. Hi, Trudy, we're hearing you. We were.
Hi.
Think you're breaking up, Trudy. I'm not hearing you properly. Are you hearing Dr. Bowen? I'm not hearing you.
Not able to hear you.
Trudy, you're really breaking up. We can't hear you. It sounds like gibberish. You want to type it in the chat if you could? I couldn't understand what it was she said. Anyone else have any suggestions or comments for Dr. Bowen? So are you part of the IVU team? Are you with IVU, Dr. Bowen?
I'm not. I was my friend Rich, I think, suggested when Katie asked about.
Okay, right.
I mean, I love IVUmed. I'd love to be involved, but I have not done like a trip.
Yeah. Well, hopefully you will, and you'll get to come to Trinidad and meet us.
too.
And you already know Trudy, so you have that link. So
Hi, Diana. Can you hear me now?
oh yes, we can.
Hi. Oh, I was just saying hello. Yeah. How are you?
I'm good, thanks. It's so good.
Are you enjoying Chicago?
Yes, love Chicago.
Okay, nice. It would be really nice if you guys come down. So before COVID, we actually started a CHOP Global team.
Yeah.
Chris and Caleb came down, and Dana came down with them the last time. So
Awesome.
definitely, if it's something you're interested in, you can probably come down with them whenever the
Yeah, I'd love to. That'd be awesome. It'd be so fun.
Yeah.
Or maybe we'll save this case for you, and then you can come and help. That sounds like a great idea.
Good continuity. Yeah, sounds good.
Yeah.
All right. Well, thanks so much for inviting me to do.
Thanks. Yeah, and I'll be in touch with Katie and see if there's other lectures we're interested in. Yeah.
Thanks very much.
All right.
Thanks a lot.
Thank you, Dr. Bowen.
All right, thanks. Yep. Take
Bye.
care. Good night.
Katie, thanks for organizing. Yeah.
Yeah, of course. Let me know
Yeah.
what other lectures you're interested in.
Yeah, we'll chat and we'll talk about that thing about the research you were talking about. We'll definitely move that forward. Yeah.
Yeah, I'm glad you're interested.
Take care. Thanks.
Yeah,
Bye.
thank you so much. Bye.
Bye-bye.